Hello, everyone. My name is Tina Kaplan, and I'm the Vice President of Provider Relations for Magellan Healthcare. Welcome to our Cardiac Provider Clinical Training, presented by Dr. Rosalind Watman, our Magellan Healthcare Medical Director for Cardiology. Dr. Watman is a board-certified cardiologist and has over 30 years of experience. She's worked at Magellan Health now since 2014, first as a senior physician reviewer, and now she is currently our medical director, as I said, of cardiology, where she is very involved in the training of physicians for the appropriate utilization of cardiac studies. In addition, she is also involved in creating and implementing our cardiac guidelines, which get reviewed on an annual basis. And she collaborates with the health plans and providers in order to provide quality patient care. Dr. Watman assists our provider relations area in educating physicians on our clinical guidelines for cardiology. So the purpose of the training today is to increase physicians' awareness of the medical necessity guidelines related to cardiology, so that the clinical documentation can better support these cardiac requests. And now at this time, I'd like to turn it over to Dr. Watman, who will review the agenda for today. Thank you.
Thank you, Tina, and welcome everybody. As Tina discussed, I will be speaking about the documentation that is needed for cardiac studies. And in particular, we will be discussing the MPI and the stress echocardiogram. We will go through symptomatic and asymptomatic patients, follow-up of patients who are post-cardiac revascularization, pre-op evaluation, cardiac transplants, and the definition of an uninterpretable EKG. So one of the important things that the offices need to know is that they need to provide a recent office note. Now, for pediatric echo requests following up congenital heart defects, we can accept office notes up to 2 months, provided that there was a plan for the study in the office notes. For all other studies, we would like them to be dated within 6 months. An important part of the cardiac studies is the EKG tracing. And we will accept a cardiologist's interpretation of the EKG if the reading is of enough detail so that we can determine the need for the imaging. So interpretations such as possible old anterior infarct or non-specific ST wave abnormalities would not be enough. And in those cases, the tracing should be reviewed and requested. And if the reading is submitted, it should be performed by a cardiologist. We also, an important part of the nuclear stress testing is clear documentation of a reason why a patient would be unable to walk on a treadmill. So generic statements such as back pain or orthopedic problems are not acceptable documentation. Our peer-to-peer documentation is important in clarifying any discrepancies that are in the notes. So verbal clarification that was present in the documents is then clarified on the peer-to-peer. This can include conflicting information or typographical errors. If the information, however, is new and is needed to approve the request, the information must be uploaded on RADMD or faxed and then reviewed before an approval is possible. So now going into the two studies, the MPI or nuclear stress test and the stress echocardiogram. So in general, an MPI is approvable over a stress echo in certain situations. And if you look at the first box, these situations include a poor quality echo image as documented in the echo report, an inability to exercise, again, that needs to be well documented. Patients that have a history of a prior CABG surgery can have an MPI over a stress echocardiogram. Those with an ejection fraction heart function of less than 40% are also allowed to have an MPI over a stress echo. Patients with severe chronic obstructive pulmonary disease on HOMO2, making it very unlikely that they will walk on a treadmill, is another situation, as is a pacemaker or a left bundle branch block or atrial fibrillation on an EKG. A few other indications in which you can do an MPI over a stress echo is high pretest probability. And this is determined by the Diamond-Forrester classification. The Diamond-Forrester classification takes into account the patient's age, gender, and symptomatology. Patients that are started on a 1C antiarrhythmic, such as propafenone or flecainide, are also allowed or approved for an MPI if it is requested, or if there is concern for an arrhythmia with exercise. The stress echocardiogram is approvable for exercise hemodynamics, and this is to assess the degree of valvular heart disease, such as mitral regurgitation or aortic stenosis with exercise, when the results would affect management. And that's an important part, is we want to see that the results of the test will affect whether the patient has a procedure, or if there is a discrepancy between the physical exam findings and the transthoracic echo findings, and again, when the results would affect management. So starting with symptomatic patients, and in general, these are patients who we do not know have a history of coronary disease. It's a patient generally that comes to the office with a complaint of cardiac symptoms, such as chest pain or shortness of breath with walking. First thing we do is determine the pre-test probability. And again, this is using the Diamond-Forrester classification, which is included in our guidelines. And again, based on the patient's age, gender, and type of symptoms, we determine their pre-test probability. If the patient has a low pre-test probability, we recommend that they have a plain exercise treadmill test. If the EKG is uninterpretable, they can have a stress echocardiogram. For patients with an intermediate pretest probability that can walk and have a normal EKG, we will again divert to an exercise treadmill study. And as I previously stated, those patients that have a high pretest probability can have a nuclear stress test. But it's important to realize that if the patient cannot walk, and again, that needs to be documented, whether they're low, intermediate, or high pretest probability, they can get the MPI or nuclear stress test. So how do we determine the type of chest pain? So in general, there are three types of situations where patients have chest pain. They can have substernal chest pain or discomfort with pressure-like symptoms radiating to their left arm. It can be provoked by exertion or emotional stress and relieved by rest or nitroglycerin. If the patient has all three features, that is considered typical chest pain. 2 out of the 3 features is atypical chest pain, and 1 out of the 3 features is non-anginal. So what do we do with the asymptomatic patient? Well, in general, there is no testing for these patients unless there are certain situations. One, as I stated before, they're starting a 1C antiarrhythmic, such as flecainide or propafenone. On their EKG, they have an unevaluated Q wave, suggesting that they've had a prior MI, or they have wall motion abnormalities on their echocardiogram. If they have a left bundle branch block on their EKG, which has never been evaluated, and we need that documented, they can also have an MPI, even without symptoms. Or if they have EKG evidence of myocardial ischemia, including substantial ischemic ST segment or T wave changes, they can have either a nuclear stress test or a stress echocardiogram. And again, this is without symptoms. So what do we do with the patient in which we've done a prior testing and we still did not have an answer as to the cause of their chest pain? If they've had an exercise stress EKG and they have an intermediate Duke treadmill score, and our guidelines include a section on how to determine the Duke treadmill score. It's based on the length of time that they stay on the treadmill, their symptoms, and their EKG changes. So if they do a plain treadmill stress test and they have an intermediate Duke treadmill score, they can have additional imaging, preferably a stress echocardiogram. If they have a coronary CTA and they have a 40 to 70% lesion, they can also have stress imaging, preferably again, a stress echo. If the patient does a treadmill stress test and is physically unable to reach their target heart rate, or the length of time that they are on the treadmill is not sufficient to make a determination, those are patients that we would approve a nuclear stress test. And just a word about dobutamine stress echocardiograms. We do not require that the office do dobutamine stress echocardiograms. We leave that to the discretion of the ordering physician, but we would not recommend it in our denial. And what do we do with patients that have had prior revascularization, whether it's a PCI, an angioplasty stent, or bypass surgery? If they are asymptomatic and they had a PCI or a CABG and they have no other blockages besides a vessel that's stented or bypassed and they have no symptoms, we do not recommend routine follow-up testing, except in the case of high occupational risk. And this includes patients that are in jobs that place them and the people they work with at risk, such as school bus drivers, public safety officers. Those are patients that we will allow stress testing every 2 years. Of course, if they have symptoms and they had a prior PCI or a CABG, we will allow imaging. And if they can walk, and assuming they haven't had a bypass, because the CABG patients are allowed approvable for an MPI, but if they can walk, we would endorse a stress echocardiogram and an MPI if they cannot walk and have symptoms post-revascularization. And this is basically a summary of what I had previously noted. This is an asymptomatic patient, but it's had a left heart cath and they had a greater than 70% blockage. They can have testing if, and an MPI is what we would endorse if they cannot walk, or stress echo if they can walk, even if they're asymptomatic. And of course, if they're symptomatic, we do allow stress imaging. However, it's important that there is noted in the notes a plan to do a procedure if something is found on the testing. And some other situations in which imaging may be requested and that we would approve is patients with a prior ACS or acute coronary syndrome. And this is assuming they did not have any other testing to evaluate this, such as a left heart cath. Patients with newly diagnosed heart failure, patients with new wall motion abnormalities, patients that have frequent ventricular premature contractions. In general, we recommend an exercise treadmill if they're able to walk and if they have a normal EKG. And the last three are some situations that are somewhat rare but do come up, and that includes Kawasaki's with coronary aneurysms, patients that have had radiation therapy, and patients with anomalous coronary arteries. What about the pre-op evaluation? In general, we do not endorse testing for patients that are undergoing low-risk non-cardiac surgery. For patients that are having high-risk non-cardiac surgery, that includes suprainguinal vascular surgery, intrathoracic or intra-abdominal surgery, and can only perform less than 4 METs. And 4 METs is what we would equate to the activities of daily living. And they have a cardiac risk factor, such as a prior MI, diabetes, a creatinine of greater than 2, or heart failure. And they have not had a non-invasive testing within the last year. And the management will change and again, this may stop them from having the surgery. If that management will change based on the results, those are patients that we will approve stress imaging. Solid organ transplants, and this includes kidney, liver, and also pancreas prior to transplant in patients that are greater than 60 years of age, have risk factors such as smoking, hypertension, hyperlipidemia, diabetes, renal failure, or a prior history of coronary artery disease, and cannot perform 4 METs, can have a nuclear stress test yearly before their transplant. And in general, this is at the discretion of the transplant team. And for patients that are post-cardiac transplant, they can have stress testing imaging. It can be a nuclear stress test, assuming they haven't had a left heart cath annually for the first 5 years. After 5 years, if they have evidence of vasculopathy, because post-cardiac transplant patients are at increased risk for coronary disease, they can have MPIs yearly without diversion. And I just wanted to spend a moment on what an uninterpretable EKG is. And these are patients that we would not be able to interpret a plain treadmill and that we would allow stress imaging. We define an uninterpretable EKG as an ST segment depression of greater than 1 millimeter or more. So this is not non-specific ST wave changes, which is another reason that we do prefer that the tracing is sent. If patients have ischemic looking T waves, those are also patients that the treadmill would not be interpretable and can have stress imaging. Patients with left ventricular hypertrophy, with repolarization changes, patients on digoxin, patients who in the physician's opinion would not be able to get their heart rate above 50, or for reasons being that they may be on medication such as beta blocker, and there is an anticipated suboptimal workload. And a right bundle branch block is not necessarily a reason to not do a plain treadmill study, and that's we manage that on a case-by-case basis. So that basically covers the indications for stress echo and MPI testing in the cardiac patient. And I'd like to turn it over to Tina now. Thank you very much.
Thank you, Dr. Watman. So on this slide, slide 19, we have included some contact information for both you and your office staff. Now, for checking statuses on authorizations and also initiating an authorization request, you can visit www.radmd.com. RadMD actually houses our clinical guidelines as well as all of our educational documents, such as the tip sheets that Dr. Watman alluded to for cardiac, as well as our frequently asked questions and our quick reference guides. We also have PowerPoints like this for the non-clinical staff within your office or your administrative staff, which will walk them through the process of getting authorizations. To initiate a peer-to-peer, providers can call 1-888-642-7649. If you're having technical issues or just for routine questions, you could call our 800 number at 800-327-0641, and that's our provider service line. We have provider service associates readily available to help you and assist you with getting access to our website, RadMD. For additional information, you can click on this link. The link will provide you with detailed information on who your provider relations manager is. So if you have more in-depth training that needs to be done for your office, we can conduct a virtual session such as the one today with your office staff and walk them through getting authorizations for Magellan Healthcare. So I would conclude by saying thank you very much for listening to this training today on cardiology. And please reference any of these contacts if you have any questions. Thank you.